All right, we'll get going here. Thank you, everybody, for joining us. Happy Thursday. We're excited to be teaming up with BCMS, who we consider to be the nation's leading physical therapy compliance consultation firm. They've been providing outpatient therapy compliance since 2000. Their services include billing and coding and documentation consultation, provider enrollment and credentialing, offsite chart audits, and a compliance program that contains policies and procedures to run your practice accurately. So we wanted to offer this webinar to equip you with some knowledge regarding coding behaviors, utilizing CPT code definitions to support codes build, and telling the story throughout your documentation, as all of these topics are valuable in the event of an audit. So BCMS's founder and CEO, Mary Dolong, will present for about 30 minutes before opening up for a Q&A. And as questions arise, please just enter them into the Q&A field at the bottom of your screen, and we'll answer them at the end. Thank you again for joining us. And without further ado, over to you, Mary.
Good afternoon. Well, it could still be morning in some places. So it's a pleasure to be able to present to you today. A couple of housekeeping things. If you will make sure your mic is muted, unless that was not controlled by Tim, that would be great. And as he mentioned, we will take questions at the end. If we do not get to all the questions, if you will write them succinctly in the chat box, I will try to answer those via email to you, or actually not to you, probably to Prompt, and then they can disseminate the answers. So just a word about the opportunity we have to work with Prompt. We have, BCMS has audited thousands of charts, and I know that sounds really exciting, but we have over the years, and actually we started when we were all paper, so that was really fun because we dealt with handwriting. But now in the age of electronic medical records, we are seeing when the EMR company can be friend or foe. And we want to make certain that you take advantage of the opportunity that you have with Prompt, because they have a reputation for listening to their clients. And that is so important. So if you're having problems with something, or you've been told something about this is compliant, that's not compliant, they do listen. We hope to be engaged in helping assure that. And one thing I will stress, we can have a great EMR, which Prompt is, but that does not mean you will not get audited. So if anybody is listening to this to think that we will eliminate your potential for audit, please be aware we can't do that. Wish we could. We do not control that particular aspect of regulation. So let's go ahead and start and proceed here. So a lot of people say, every time I see this, I've seen letters, my friends have told me this, and everybody panics. And you know, it is a scary thing to be audited. You wonder, what did I do wrong? How did I precipitate this audit? But the worst thing you could do is run scared. We want to make sure that you know a few things about who the auditors are, a couple of things they're looking at. This is the tip of the iceberg. We're not getting into how you handle submitting documentation, that type of thing to them, although we do have a lot of tools that could help you in that arena. So let's look at the consequences. And you know, I don't like to start off with scare tactics, but this is reality. When you are audited, if you have an unfavorable audit, claims can be denied, so that means you don't get paid. You could have more audits. They could say, we need you to refund us. It could be elevated to a fraud investigation with corrective action. They can extrapolate the damages. What that means is they look at the sample they have selected, and they look at your error rate, and from that they will say, okay, we're going to apply that to the next 2, 3, however many years. Typically it's 3 years, but it can go further in the event of true fraud. Fines, penalties, and jail, and exclusion from the program. That means you're no longer part of Medicare. So that's why we consider this so important. That is why it's very important for you to do internal audits, for you to look at your documentation. we know that it's very hard to work in time to do your own audits, but you can do focused audits. Those are things that you're just going to focus on, things that are high risk, to see whether you are completing those, and we will go from there. So let's talk about the typical types of audits we have. This is not all the audits. These are the ones we typically see, at least for the last 2 years. Comprehensive error rate testing audit, post-payment and prepayment probe audits, supplemental medical review, and targeted probe audits. So those are the ones we typically see. That is not saying that it is that you couldn't have another type of audit, but those are the most typical ones. So let's just start out with CERT. And again, I'm just going to give you the tip of the iceberg. A CERT audit is you got the luck of the draw. They chose you randomly. It has nothing to do with your documentation, because obviously they can't see that prior to auditing you. It has nothing to do with how you build on the claim or any complaints that were made against you. It's nothing like that. It is strictly a random audit. Usually it is a date of service, usually not many more than 1 or 2 days, if the most. But at this point now, in the beginning, this really was to check to see if your Medicare administrative contractor was looking at the billings and that they were paying their providers appropriately. Now it has taken grown an extra leg, and if they find something that is aberrant, they will and can send it to another level of auditors. And a lot of times that's how the TPE audits begin. So see this bright yellow envelope? Alert your staff, whoever handles your mail, very important. Always keep envelopes. This particular one is for the CERT audit. And you want to keep every single bit of communication you have, highlighting dates and all kinds of, any of the deadlines, that type of thing. But this is important. Keep this yellow envelope and any other envelopes that you get with as it relates to audits. So let's post-payment audits. This is they've paid you, and now they're saying, we're going to go back and we're going to look at something. And typically this is to make sure there is appropriate medical necessity documented, and that the billing is in compliance with Medicare rules and regulations. These audits, most of the time, are going to focus on CPT codes, and they look at how you compare to your peers. Your peers could be within your clinic. It could be your peers in your city, your state. It could be across the universe of providers in the United States. The ones we typically are seeing here, let me move our picture because I can't see what I'm writing here, are 97110, 97112, 97140, and 97530. So those are the typical ones we are seeing right now. And they expect you to respond with the appropriate documentation and support documents within 45 days. And they are supposed to, and I said supposed to, respond to you within 60 days. Okay, so when we get to TPE audits, many of you have probably heard of those. They're targeted probe and education audits. When this came out a few years ago, prior to COVID, because they held these during COVID, they stated that what they'd like to do is stop chasing the money and start educating so that you know how to prevent aberrant billing and coding and documentation. And so they built in these education sessions. Some of the MACs, and these are conducted by your MAC, and your MAC, the Medicare administrative contractor, if you're not sure who your MAC is, we can certainly get that information for you. I'm sure Prompt has it as well, but you need to be familiar with your Medicare administrative contractor. But what they do is they are looking at claims data, and they are looking for people who you can just look at the claim and you can see that there are issues on that. And then they're going to be evaluating you on your claim rate as to whether you have to have multiple sessions of education or whether you're good to go and they're going to not bother you for a year or so. Typically, TPE audits have 3 rounds of audits. So they do an initial one, which was based on post-payment. If you do well, then, as I said, you're free to go. If you stumble and have a higher error rate, then it's acceptable. They'll say, let's do education. You get another opportunity to submit records after that education is completed. They'll look at it again. If you do well, you're free to go. If you don't, you have more education, more audits. If you do not pass third round, then often that can go to the next level auditor. And that's when they're looking more often for fraud. Let's talk about what we call SMRC audits. So this is the Supplemental Medical Review Auditor. You probably are familiar with those. They're the ones that audit our claims over the $3,000 threshold. And it is not just based on a dollar amount. It's based on hitting the $3,000 threshold and some type of aberrant billing or coding behavior. Last year, they all of a sudden had a new project assigned to them from the Office of Inspector General, and they audited evaluation. So the date of the evaluation, we had never seen that. There was a real specific reason. They were looking at who were signing evaluations, were the evaluations complete, when the plans of care were signed, how, and all those things, how they tie in. So we had a whole series of those, and it was very, very aggressive. And this is the envelope that comes with the SMRC audit. So if you get this lovely green envelope from Noridian, they are the SMRC auditor. You want to take heed and move very quickly on complying with the request. Again, always keep communication from any payer that you have regarding audits and deadlines and those types of things. The final one, which I didn't have on the original list, I actually added yesterday because I had a client we were working with, and he said, oh my God, I got this audit, and it says they're randomly selecting charts. And he said, am I just, I just was randomly selected. I said, no, you were specifically selected. They are randomly selecting charts over a specific period of time. This auditor is a scary one. They're the ones that are absolutely looking for fraud. And in their letters, this is what you will see. This is what it says to the provider. As Unified Program Integrity Contractor, we are required by CMS to analyze claim payment data. And they've got to look at the highest level of risk and appropriate payments. Specifically, we are required to investigate situations of potential fraud, waste, and abuse. There has been, and you see the dots, there's other language in there, credible evidence regarding data analysis findings, and allegations, billing practices, and so on. So something has alerted them that this is serious. So that they don't have a colored envelope that I have seen, but if you see anything that says Noridian, if you're on the West Coast, that could be your Medicare MAC, but I certainly would open it one way or another because that could be a TPE audit, or it could be your, excuse me, I just told you that wrong. That's for a SMRC. These contractors are geographically allocated, so it could be one of several program contractors. You want to pay attention and read. If you see that language, you want to be very, very alert to getting your documentation, getting it in. And in these particular situations, we typically advise that you have some consult support because you don't want to mess up. You want to do it right the first time in your submission. So, are your claims subject to a whistleblower? You could have somebody who's saying, we're watching claim submission within your office, say that. You could have your someone who's in competition with you, make allegations. So there's lots of heartaches, but most of the time your claim does it. So this is the paper version of the 1500 form. Most of you are probably using that. I guess I should ask Tim and Mike whether y'all have very many rehab agencies that use the UV04, of course. But most of you sitting there probably use the 1500 form. And this is a sample of it. Where we see problems on this, it's obviously in this section where we have our CPT codes. And when you look at the number of units, and it says 3 or 4 97110s, and you see repetitively the same thing, the same codes, the same number of units, that is a red flag. Another area that's a red flag is right in here. This is where you put your ICD-10 codes. Now we can only put as many medical ICD-10s as we get from the physician. We can certainly relate in our documentation that a patient states they have congestive heart failure, they have uncontrolled diabetes, they have peripheral neuropathy. But unless we actually have that diagnosis, we cannot put it on the claim because that's a medical diagnosis. We can relate it in our documentation. That helps us. I would encourage you, if you have a complex patient, to get that ICD-10 code to help support your coding and billing, and to make certain that you are not duplicating that when you are documenting on the claim the impairment diagnoses. They are looking at what you're going to have to do for this patient with this condition. And if you repeat medical diagnosis, you're not saying the patient has difficulty in walking or the patient has X, Y, and Z. You're just reiterating the medical diagnosis. That is a major issue. You want to make certain they can see you need to work on the following deficits, functional impairments, those types of things. So this claim can be your friend, it can be your enemy. So what are the focuses of these payer audits? And I don't know if I hit one. No, I'm sorry. Okay. They look at people or providers, and I'm going to use the word provider loosely because in Medicare, provider really is a therapist in private practice, not in private practice, excuse me, in a rehab agency or a core. Those of us that are in private practice are called suppliers. But in the world of payment, we all kind of fall into that provider arena. So I'm going to use that term to just keep it simple. So they look at those that exceed the norm and those that are under the norm. And you're going, really? They're going to look at those who are under the norm? Well, one of the things that I learned in a course that I was taking, I'm certified in healthcare compliance. I have continuing education just like the rest of us, and for licensure. But I was listening to the Office Inspector General, and he said, we look at both ends. We look at both ends of the bell curve because fraud can happen at all levels. And he was very clear. He said, those of you who think you're flying under the radar because, and he specifically used PT as an example, you never hit, and at the time when he did this, we had the cap. You never go over the cap. You never go over the $3,000 threshold. We're looking at you because we have an allowance built into the system to expect a certain amount of patients that would go over these thresholds. So we are looking at you. Avoid being an outlier. So here's the bell curve. You want to not be in that white and blue section, not at all. You want to make sure that you're on the bell curve, and that means that you are not exceeding the behavior, billing and coding behavior of your peers. So let's look at what the exceeders what are the categories that relate to them. So they bill more units or more visits or units per hour of therapy provided in a day. Let me tell you how this can happen and come back to really cause you a problem. So you are a therapist. I don't know how many visits, how many units a day you individually deliver. But when you have a PTA, that increases that many visits, that many units, that type of thing. If you are working with a student, you are supposed to, for Medicare, be shadowing the student. So you shouldn't have any double visits or units or anything like that. So y'all should be one. But some people do sign off using their NPI on claims for therapists who are not yet enrolled in Medicare. And that's a whole controversial subject, but I will tell you, and it's very clear in the program integrity manual that Medicare has, that you may have a therapist who is not enrolled in Medicare, and they may treat Medicare patients under the direct on-site supervision of an enrolled therapist. What it doesn't say is you can bill for that. So if you were billing, if you were generating claims for that, then that's that many more visits or that many more units that you are accountable for, but it's also against the regulations. The regulations clearly say in order to bill for Medicare beneficiary treatments, you must be enrolled in Medicare. And I know there's a provision in the manual that says this direct supervision, but again, it says treat, it does not say bill. Okay, so we go to the next one. Billing the same CPT codes redundantly throughout the episode of care. We are claims happy. We generate a lot of claims. We have a lot of information on the claims because we do a lot of things to our patient in a visit. So if they look at Mary DeLong and they say, Mary DeLong uses the same 3 codes, the same number of units for each of those, every single patient, regardless of their diagnosis. What is that telling them? They're saying, this isn't right. All of these patients with different diagnoses can't warrant the same interventions. So they are looking at a claims level. They don't even have to look at your documentation. Okay. So the exceeders, again, is it a problem for us to go over the thresholds? No. But it is if you have aberrant billing behavior. So you go over the $3,000 threshold and you are one of these redundant coders, or you have a lot more units per visit or more units in general generated under your NPI, they're going to be looking at you. Okay. So you could really be screaming, hey, I am a problem. I'm a problem provider. And again, with the EMR software that you have, a lot of these things can be picked up and you can get, different ways of handling it. But redundant coding, if that's how you're coding, you're making a statement about your clinical judgment. If you regularly bill a lot more than are under and over your peer group, again, it's read on the claim. If you do not use modifiers right, that's the KX modifier, that's the CCI edit modifier, the 59, the PTA modifier. If you routinely are cited for not using the correct modifiers, they're going to look at that as deliberate. When they deny a claim, that is saying, we don't consider this acceptable. But even the OIG has said, just because there's an error doesn't mean there's intentional fraud, and we don't look at it. But if you continue to make the same mistake and not correct it, then it could be considered a false claim and get into other areas of fraud, waste, abuse violations. So very important that you think and you have people looking at your denials, evaluating why you have denials, and taking corrective action. Failure to use adequate impairment ICD-10 codes. I mentioned that earlier. If you just regurgitate the medical diagnosis and you don't show any impairment, they're going to say, well, what are they working on? So we need to make sure we do that. And again, I just stated reckless disregard of denials without showing that you have taken corrective action by not doing it again. So let's focus on redundant coding. And, you know, I'm a PT, our practice was manual therapy. We did tons of necks and backs. So, you know, we're going to have a lot of the same CPT codes. However, I propose to you that we don't look at the definitions of the codes closely enough, because what might be exercise today could be considered neuromuscular or eventually therapeutic activities. So you need to know the code definition. If you do not have the formal official definitions set forth by the AMA, you need to have it. We do have webinars on billing and coding that cover all of that. That's something that could be available to you. But you want to know that because, again, that's a higher level possibly of coding. It also shows you're moving a patient from fundamental activities to more advanced activities to functional independence. And what is the actual activity you've performed? You know, I had someone challenge me one time. He did straight leg raise. He coded it as neuromuscular. And I said, you know, I bet you a lot of your peers would say that's exercise. And this was based on his documentation. And he said, no, when I get in there, you know, I'm working with people who have memory, muscle memory loss. They absolutely have no coordination. They don't even know where their body is in space, you know, and I'm working with that. I said, well, then you need to say that, because that definitely, just a few of the terms in neuromuscular, when we're talking proprioceptive, balance, coordination, those types of things, those words can be used and it's very easily associated with the correct activity. And also the intervention's purpose. And I've used this, those of you who have heard me speak before, I've used this probably since 2010 in my presentations, but it's the clearest one I can give you. If you are using let's say a physio ball, and you are trying to do, you know, core strengthening, stabilization, whatever on that, and it's coded as exercise. Perfect. But the next few visits and you change it and you're really working on balance. So you're doing balance activity on the physio ball. And down the road, you're still using the physio ball, but you're doing therapeutic activities. So you're using ing words, you're lifting, lunging, pushing, pivoting, all those types of things that describe functional, more full body engagement, much more challenging. So while people sometimes just say physio ball activity and then don't define what it is, you know, what is it? So use the definitions. Also, and one thing that we do create heartburn for our patients is they see a physio ball, they sat on it, they did balance, whatever they did, but they still see it as a physio ball, and they go up to get their bill for the day, and it's different because exercise doesn't, the fee schedule is different for exercise and neuro and therapeutic activities. That's confusing to the patient. They use the same tool, but you had a different purpose. It's important for them to know that, because your front office people they're gonna have to answer that. So when we look at this, and this is a real case. This is one chart that one case I audited a number of years ago. The diagnosis was difficulty in walking. They had a total hip replacement. They billed 22 visits, 1 evaluation, 1 reevaluation, and 66 therapeutic activities. And first of all, if somebody has a total hip replacement and I don't see gait in there somewhere, I'm going to wonder, they're really strong and maybe they have balance, but they can't walk because you haven't done anything to assess or to work on their gait. I had total knees, and I can tell you, we did gait training on when I had my total knee replacement. So again, they're smart enough to say, God, you should have been doing some of that, you know. So this is what I gathered from the documentation, and this is where we get into the potential for looking at a false claim, documenting something that is not billed appropriately. So this is what their documentation should have been billed as: 1 evaluation, 1 reeval, 24 exercises, 2 gait trainings, 12 neuromuscular, 12 manual therapy, and 16 therapeutic activities. First of all, you're probably going to make more money with those codes that have a better value, RVU, but also it's correct and it shows clinical progression. So that's very, very important for you to consider. Think of the code description. So this one is pretty simple. You can see how you can show progression just in how you do it. So you might start with some things with the patellofemoral pain patient, mat exercises. You're working on foundation things, strength, range of motion, whatever. And then you're moving to balance. So that again is showing more challenging. They have to have the strength, they have to have the range of motion, or at least progression into that area. But now you are adding neuromuscular to it. And then you can see as you get further into it, we're looking at dynamic activities to improve functional performance. Again, those are ING words, typically engaging the full body versus a single muscle group, a single joint, that type of thing. So think about what you're doing when you code your claims and you code what you did. So look to purpose, look to definition, look to demonstrating progression. So when the coding tells part of it gives you a picture of what's happening, you have, again, just from the claim, redundant coding, it shows little skill or progression at the claims level. And when you have progressive coding, it indicates clinical decision making and it shows progress. So you're less likely to incite an audit when you are showing this type of behavior in your coding and billing. So it is your choice. So remember, if you think of the CPT code definition work when you're coding and documenting, think of purpose, not equipment. Example of the physio ball. These are the things I had mentioned before. And that you will be showing progress. So that's what they expect. We're supposed to, under restorative or rehabilitative therapy, we are mandated to show improvement. You can show it at the claim if you know how to code correctly. Okay, so there is a financial advantage if you code correctly, and I'm talking about when we're looking at the Medicare 8-minute rule. Now, most of what I've talked about has to do with Medicare, but I'm also going to cover AMA's coding greater than 50% of the unit, because that's part of it. Not all of us are 100% Medicare. So we have the option to use a different unit coding methodology. So when we look at, and I'm trying to give you a couple of examples with the, and I know y'all know how to count the 8-minute rule, so I won't go over that. But if we have the same patient and we have 24 minutes, the AMA rule, if you're using different, and I'll show you this again, because theirs is, it has to be a different CPT code. If you have the same PT code in 3 units, that doesn't work, and you'll see with these examples. So 8 minutes of 3 different units is going to give you 3 units here. If you are Medicare, because Medicare takes the cumulative value, 24 minutes is only going to get you 2 units. Okay, but if we go then looking at this time example, and again, I mentioned if you have duplicate codes under AMA, you'll see what happens. 16 minutes of 97110 8 minutes of 97140 for a total of 24 minutes, you get 2 units. You do not have the advantage of the extra unit when you go over the 7.5. I rounded to 8, but in general, 15 minutes is what we allow for most of our CPT codes. So half of that would be 7.51, round it to 8. So if you do not meet with the AMA example, if you do not meet the full unit, so 15 minutes, and at least half of the second unit, you are not going to get that extra unit to bill. And this is exactly the same with Medicare. It's cumulative. You're going to divide 24 by 15. You're going to get those 2 units. Okay, so when we look at this example, so we have AMA rule. Again, they had 33 minutes of exercise, 7 minutes of manual therapy for a total of 40 minutes. They only get 2 units because they did not reach the halfway point for manual therapy. And they only met 2 15-minute units. So that extra 3 minutes, you really lost it. You get 2 units. On Medicare, because they add them all together, you get 3 units. And in this situation, the 3 units would be 2 97110s. And because that's only 3 minutes left here, but this is 7 minutes, this is greater than 3, you get to take those 3 minutes, and that is 1 unit of 97140. And that's always a confusing one, but basically what happens is you get to use those leftover pieces, and it's going to go to the unit that has the most minutes in it, or if they're exactly the same, you get to choose. Where did you accomplish the greatest result? So if they were all 777, you would have to choose which unit you wanted to code that to. So when you're dealing with Medicare, it's important to understand that it is the total minutes billed for the on-one codes. And AMA counts minutes by the code. So if you think of this, let's see if I can see it. When you have Medicare, the leftovers are important because those can be put into possibly another unit. When you have AMA, it is very good to be different. So using the different codes. Now, I'm not encouraging you just to build something to get an extra code. Again, you have to meet the definition, you have to meet the purpose, but that is the benefit of knowing how to build these. I know a question is going to come up: who uses the AMA rule? Who uses Medicare? From a Medicare perspective, obviously, traditional Medicare is going to have the 8-minute methodology. That's not automatically the case for Medicare Advantage plans. They can pick and choose methodologies. They have to provide the same service the traditional Medicare does. So if Medicare provides physical therapy, they have to provide physical therapy, but they can decide whether they're going to do multiple payment procedure reduction. They had an option with the functional outcome limitations, whether they're going to use the AMA methodology or whether they're going to use the 8-minute rule. Your commercial carriers, that's up in the air. You have to know your contracts. You have to know what their coverage and payment policies are. What I typically tell people is if they are dealing with a Medicare Advantage plan, you obviously have to know what their coverage policies are. I tend to lean towards following Medicare for those because patients many times switch at the beginning of the year in and out of plans, move from traditional to Medicare Advantage and vice versa. If you're in the middle of an episode of care, that's a problem, because what are you going to do? You're going to change the way you code. Is what's going to happen to plans of care that might need to be signed or not need to be signed, or if the coverage terms are different. So I tend to lean towards going to Medicare methodology, whether it's documentation, coding, and billing, unless the MA plan specifically indicates something different. So you have to know your plans. On commercials, again, if the plan is silent, if they do not talk about general supervision, direct supervision, plans of care, how you code, if they are silent on those, then you can defer to the standards of your profession. And also I would probably use the AMA methodology, because there's no reason for you not to use that if you can. It is there. AMA controls the codes, how we time them, those types of things. So it would be a good rationale to use in the event you were audited. And if, again, you have really researched your plans. So, as I said, leftovers can be valuable, so as is being different. So that was it in a nutshell. I think we're sitting at about 35 minutes. So I'll be willing to take any questions you have.